Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here with Tanner, and today again we're really excited to bring on another amazing speaker. We just finished up with Bree Brown on our previous episode talking about emotional intelligence and how that's something that often is a key characteristic that separates or elevates a CRNA to just an exceptional level in terms of their view and the minds of other staff members to interact with them, just the emotional intelligence, ability to deal with those in the OR, deal with patients, have verbal anesthesia. How do you get through school dealing with different personalities is such an integral part of how we grow and how we learn and how we become successful anesthesia providers. And today we're going to continue that type of conversation, but just with a different spin. We're really excited to have Ray Ramos on today. I'll have Tanner introduce him here in a second, but we're going to talk about the idea of how do you basically a survival guide. What's your rotational survival guide as you go through different clinical sites, different clinical environments, different preceptors, just different areas of training. And often when I talk to those that are going through school, the biggest feedback I get is the hardest part is not the learning of the anesthesia. It's just the constant feeling of being uncomfortable as you bounce around from place to place, different people, different interactions. And how do you navigate that while you're also learning the anesthesia side of things?
Yeah, like Cole said, we are here in Austin, Texas at the USAP conference, the Future Leaders Conference, and it's been an awesome weekend, and it's been really, really fun to get to know everybody here. Ray's someone that we've met at the national conference in Nashville, and we feel like we've known you for a long time. So we're really honored to have you on, and I know you guys will benefit greatly from his talk. Let me introduce Ray. Ray is a chief here in the Austin, Texas area with USAP. He's also the vice chair of the USAP National Care Team Advisory Committee, which helps drive culture and informs best practices for the over 2,500 CRNAs nationwide. So he is very well connected and very well versed in dealing with, people coming into different sites and clinical sites. And he's had a lot of experience managing different people coming in through for rotation. So it's an honor to have you, Ray, and thanks for being with us.
Tanner and Cole, it's an absolute honor to be here with you guys. Welcome to Austin, Texas. Listen, I am extremely excited to be here with you guys and talk to you about something I'm very passionate about. We do a lot of education in Austin at USAP Central Texas. So this conversation we're going to have is something that we have with every single student that comes to rotate before they even set ground in the clinical environment. A lot of it's just kind of to alleviate anxiety, to help them kind of give them a heads up of what to expect, and also to reassure them that they're entering a safe place, a place where we are there to cultivate their growth and help them become the next wave of CRNAs. So I think this is a really valuable information. The people that I've shared this with have been so grateful and have even come up to us later and said, hey, listen, thank you so much. You really helped to prepare me for that first day. Because I tell you, before I started my clinical training in Colorado, I wish I would have had somebody to sit down and share this with me. And I would probably save me a little bit of time and a lot of sleepless nights before I started. So I'm excited to jump in with you guys and share this. And hopefully one or two of your listeners will find value in it and maybe share a tip or two that may help them.
Yeah, I think you said it. I remember my first time going into the OR, I was just shadowing. It wasn't even clinical time. We were first year, and part of that was we'd go shadow a third year. So there's no pressure on me. My job is to stand in the corner and watch. And I didn't sleep the night before. I was so nervous. And so I'm sure a lot of our listeners can relate to this, but I think as we talk about this survival guide, basically, there's so many key takeaways here that I think if you are listening to this, our goal is to basically bring down the barriers, bring down the question marks, the things that might make you feel nervous. And so, can you start with that? Just kind of the nervous energy or the nervousness that somebody would encounter going into the operating room. And well, I think that's a good place to start as we kind of identify the problem of what we want to talk about today.
No, I think that's a perfect place to start because honestly, I think it's natural. It's absolutely normal to be nervous. You've gone through your didactic training and you're on your way. You finally made it to clinical. You've got so much pressure and you kind of feel like you can't make a mistake. And in all reality, you have not learned the skills yet. You got the didactic down and you've probably got it down very well, but you haven't had any application. And as many times as you might have practiced on a mannequin or in a sim lab, it's just not the same. I remember the very first time I intubated somebody, I was really nervous. And when I did the first DL, it didn't look like anything that I'd ever seen in any mannequin. And I mean, it's just a completely different experience. And I think having students hear that ahead of time to prepare them, that reiterate, it's okay to be nervous. But it's not just, you can be nervous, but there's also being too nervous. You have to be able to go past it, dig deep, and move forward. And that's where the growth comes, right? So I think one of the things we like to share with them is some of them say, gosh, Ray, should I study? What should I memorize before I get here? Should I review all the material I've studied? It's like, no, we always tell them, listen, focus on what you need to know. Focus on the induction drugs. Make sure you really know those dosages well. Have an understanding of why you're doing things, not necessarily know every single thing that we were taught in didactic training, because you're going to get some information. Before you take care of a patient, you're going to know what you're doing the day before. You have some time to look through, prepare, create care plans, and so on and so forth. And as long as you have an idea of what's going on, then you can speak to it and you have rationale for why you're doing things. You may not necessarily know how to do the technique, but if you can speak to it, then anybody that's working with you will appreciate the fact that you're doing the best that you can. And I think that's what we just try to instill in them is it's okay to be nervous, work through that nervousness, and you will eventually. I remember the first time I was in the OR, I was so nervous they asked me to start an IV. And I thought, golly, if I can't start an IV, they're going to think I'm terrible. How are they going to let me intubate if I can't get an IV? And I never had so much pressure on myself to start an IV. But the reality is everybody has a bad IV day. Everybody has a bad day where, they just can't seem to find the A-line, or they're having trouble with the ultrasound, or, it's normal. And that's what I try to instill in them, me as well as the clinical coordinators that are really doing a lot of the heavy lifting. But my job is to help them realize that, hey, you belong here. You've done your training. This is par for the course. Let's just stay focused and work with that nervousness.
Yeah, it's such a good point. I remember when I first started in the first week of clinical, I mean, you're a deer in the headlights. It's a new world. It's a totally different world. Even if you've shadowed and been in the OR before, it's just different when you're there on your actual first day of clinical. And I think it's 100% right. If you come in with this expectation that people are going to assume that you know everything and you're just supposed to just jump in and do everything, I mean, yeah, you're going to be extremely terrified because you don't know that. But that's the real nature of it, is people don't expect that out of you. And it's like I tell every student that's coming in, it's their first time at our facility, we don't expect you to just come in here and just blow us away by how perfect you are as an anesthetist. Like, you're here as part of your training. And when students realize, okay, the expectation isn't that I'm perfect, I just see that stress level start to wear off on them, and they become more comfortable, and they're able to settle in and actually learn and grow and actually perform the anesthesia in an appropriate manner. And I tell them right off the bat, I'm like, you're going to make mistakes. This is a safe place to make mistakes. I'm here with you. I had a preceptor my second month into clinical that told me, this is a safe environment. You're going to make mistakes here, but that's okay, because we have things to correct mistakes that are made. Like, if you give something that's too heavy of a dose, we have reversal agents. If you give something that's going to lower their blood pressure, we can raise your blood pressure, or vice versa. The preceptor said, I'm here. I'm going to make sure that you don't do something so catastrophic that's going to harm the patient, but I'm going to let you learn and I'm going to let you grow. And that was so important for me to hear. And it allowed me to actually relax and start to critically think, because when your emotions of being nervous cloud your judgment, you end up making more mistakes and more things happen. But I think it all starts with the idea of you need to approach clinical, especially your first few weeks, with the expectation of reality is that you're not expected to come into clinical knowing everything. You're coming in as a student. You're coming in that you're going to learn. And I tell everybody, just approach it with a humble attitude, not cockiness, and be teachable. That's what preceptors are looking for. They have a wealth of insight they want to teach you. And if you can come in with that personality of, hey, I want to learn from you, I want to grow, you're going to have a great time, and you're going to grow that much faster.
No, I think you bring up a great point. One of the things that we try to do with our students is reassure them, we're going to have you paired up with an experienced CRNA that's there to make sure to keep you out of trouble, to keep you from hurting somebody. Everybody's so worried about hurting somebody right out of the gate, and rightfully so. We're more worried about the ones that are not worried, the ones that are overconfident. Honestly, sometimes being overconfident is can be challenging and can make the CRNA that you're working with more nervous. It's appropriate to be engaged and to be ready and to be appropriate. But at the same time, we're thinking about the people that get into CRNA school. They are usually the stellar ICU CRNAs, right? They were stellar in ER, stellar in ICU, maybe even flight nurses or NICU PICU nurses. So they were at the top of their game, and it's very humbling to go back to the very beginning and be the learner again. And you're wanting to convey that you've got experience and that you're here, but you really are the learner again, and embracing that environment of learning and taking a step back and being receptive to feedback and being patient in the learning process is just the best way to approach this new field.
Man, I can resonate with that so much because, like you just said, you're a top performer. You know, you're crushing it in the ICU, crushing it, you know, wherever you came from. And then you mentioned the IV story. I think we all had that story where you're like, man, I was on the IV team in the ICU or whatever. Like I was doing ultrasounds, and if they had a tough IV, they were calling me. And now you're in the room and you are the learner again, like you just said. And there's just this added pressure where you feel like, well, one, it is, you know, you're performing while you're there because you are trying to show things that you've learned and you're trying to build that connection with the preceptor. But at the same time, you're also learning, but you feel this pressure of like, I need to get this IV. And it's easy, I think, for you to spiral when something doesn't go quite right or you're having difficulty. So you can let those emotions, like you said, if you don't harness them into curiosity and engagement, you can let those emotions also cloud judgment and cause further frustrations. And so it's something to be aware of for sure. We all feel it. We all feel those nerves, but taking them and channeling them into something productive is so important. So I when you're talking about somebody that's going into, you know, clinical rotations, maybe you've been in clinical rotations for a while, so you're going to a new place, or maybe this is, you know, first day of clinicals. I think both things apply here. How do you show that connection or that investment with the person that you are paired up with that day? How do you put your best foot forward, showing that you're there to learn and you're invested and you're teachable, I guess, but how do you make that connection with the preceptor?
That's a great point. And some of the feedback that we get we have a lot of students, and some of the feedback that we get from my colleagues are, Ray, I don't know who the student is. I've never worked with him or her. They may very well be a great student, but I don't know anything about them, right? And I think it starts off first with the student, right? Showing up with initiative, sharing the plan of care, introducing themselves, letting them know where they come from, where they're at in their training, what they're working on, what goals do they have, what are they struggling with, what are they working on this week, discussing the plan of care with them until they get an understanding or have some experience with that provider. I think that really shows one thing. It shows initiative. They're there early. If the CRNA beats the student to the room and the student walks in while we're setting up, not a good look, right? I don't think any one of us had that happen when we were in school, but it can happen. And if it does, you better have a pretty good story so you can kind of, because you better build that trust again. But I think first off, just having initiative, showing, conveying that initiative and your work ethic, getting there early, having a well-prepared plan, asking questions, being engaged, pretty much doing whatever they ask you to do. And they may ask you to do something that you're uncomfortable, you've never done. And then if they do ask you to do that, be honest with them. Hey, listen, I've only done one of these, or I've never done this case, things like that. But be transparent, be engaged, because honestly, they're especially at larger facilities where there's lots of students, sometimes those things go unsaid. And all it does really just makes the student more uncomfortable because they're in their head thinking, gosh, do they think I know how to do this? Or I haven't done this yet? Or I'm so worried about, and all of a sudden you're spiraling back to nervousness and fear when really you could just alleviate that if you just had that conversation with that provider ahead of time. And that way you're on the same page. And by doing so, they're able to help you more. So it's a real win-win to kind of show that initiative and show that investment and your interest in learning. But also, I think we're pivoting nicely to the next part of the advice I like to share, which is put yourself in the shoes of the person of that CRNA that you're in there with, right? And we often forget to do that because you're so focused on yourself. But pretend that you're the CRNA, or even if you don't even think you are a CRNA, think about when you were a nurse and you were training somebody in ICU. You don't know anything about that person that's orienting or training. You don't know their background. You don't know how long they've been a CRNA or how long they've been a nurse. And so put yourself in their shoes. What would you want to know? Like, I kind of want to know how much experience you have. Are you prepared? What are your goals? What are you working on? What are you struggling with? I think being upfront and transparent with where you are on your road to becoming a CRNA will do wonders to establish trust and to actually open up more opportunities, because they may say, oh, you haven't done that? Listen, how about the next case we go ahead and use the glide scope, or the next case we do an intubational LMA, or we do something, or hey, have you ever done this type of case with this type of procedure or this type of anesthetic? I think it does what you think it won't do. First, you're so nervous about being transparent about where you are in your training, when in actuality, it could lead to another door of opportunities of learning and whatnot. But at the same time, the most important part is you're conveying that, hey, I'm being honest with where I am. The last couple of times I tried an A-line, I struggled, and they're there to help you. And that way you're not so worried about struggling again, because you've already had that conversation with them.
I love that, because I can think of this literally happened like 2 weeks ago. I had a student with me and we go to Inspate, and it didn't go very well. And we were debriefing about it, and they said, yeah, this is just something that, I've been kind of running my head against, and it's just really tough for me to figure out a couple of these things. I'm brand new into clinical, and this has been a skill that I'm struggling with. And I've also had this situation where someone has come in and said exactly what you're talking about. Hey, this is the plan for today, whatever. And sometimes I'll ask them, sometimes it's just they're offered up, but they'll say, yeah, airways have been difficult for me. And that's a green light for me. I'm like, perfect. Okay. So when they come in, we're going to talk about positioning. We're going to talk about, our technique. We're going to talk about where you seem to be struggling. And, is it just the depth of the blade that's going in, or you're not sweeping the tongue quite enough, or whatever that looks like. We can pre-plan those things. We can do simulation, basically mental simulation of going through and talking about what we're going to do. And no part of that to me is like, oh man, okay, get out of my room. And, if you're not good at the no part of that comes across. If you're upfront and you're talking about, the needs that you have, I'm there to help. I'm there to engage with you and see how we can improve your learning. On the flip side, when it just didn't go well, and then they told me afterwards, yeah, it's been somewhere, I was just, my feeling was like, that felt like it kind of came out of left field. And then I'm thinking, man, there's so many things that we missed here. This was a learning opportunity that we missed. Now we're trying to, obviously take safe care of the patient, and we're doing different steps in the moment. But there's so many things, so many opportunities that are missed if that's not communicated up front. And just the difference in trust, like if you come tell me that because that tells me you're self-aware, areas that you're struggling, areas you need improvement on. And so I would just echo that wholeheartedly. If there is a way to build trust, it's by being transparent of where you're at. And I think those conversations happening at 7:20 are much easier to happen than at 7:40 when the patient's already there and in the room and on the table.
Yeah, to echo that, it takes a lot of humility at first, because as a student, when you come into the OR and you have your preceptor there, you don't want to give across the impression that you're weak in certain areas, but now that I'm on the other side of it, now that I'm a preceptor, as Tanner was saying, it is viewed as a strength when you come in and say, hey, I'm trying to learn, I'm trying to grow. These are the things that I feel comfortable with, but here's where I'm weak at. And it takes humility, and it takes a lot of courage to just come out to somebody you're just meeting who's going to be training you that day, or maybe you've been with them for a while, but to say, hey, look, I struggle with this. And none of us like to admit that there are things that we're weak in or things that we struggle with. And so to me, when somebody comes to me and tells me that, as Tanner was saying, like, I view that as like a green light. Like, this is great. Like, now I know how I can help you today, how I can teach you. And again, like, now that I'm on the other side of things, and now that I am viewing it from a preceptor role, it helps to have a full perspective now on, okay, I can empathize and put myself in the other shoes. Like when I was on the learning side, and I was always concerned what different preceptors were thinking, now I can see from this perspective. The preceptors, I mean, for one, it's also a stressful situation for them, because they get their assignment as well that says, okay, I have somebody that I'm precepting tomorrow, and I don't know how much they know. I don't know, do I let them have a lot more autonomy, or do I need to be walking them through basic induction techniques? I'm not sure where they're at. And so now on my end, I'm thinking, okay, this is also stressful for me. And so at the beginning, to have that open conversation and to be engaged right at the beginning and be open with each other just sets yourself up for so much more success throughout the day. And so something that I did when I was in school is when I would start the day with my preceptor, the moment they'd walk through the doors. Let's say we were doing a carotid that day. Maybe I hadn't done a carotid before. Then I would tell them, okay, here's my understanding about this procedure. And I would tell them my steps I think are going to be X, Y, and Z. But I also know I haven't done this before. So how do you like to do this? What are things that you think I should watch out for? And what that did was two things. It told the preceptor that I'm prepared and I did the homework that I knew how to do ahead of time. But I also understand that I don't know everything and that I am willing to follow what the preceptor's plan is going to be. And then the preceptor then feels comfortable and says, okay, now I know where you're at. And I also can then direct and teach maybe a different version of what they presented. And I might have learned in my experiences of doing this a few times that this direction may be better for the patient than the other. And so right away, you just show the preceptor that you're ready to learn. You're there, but you've also put in work ahead of time. And so I think that just sets you up for success. I'm a big proponent of the first minute of the interaction between a preceptor and a preceptee is going to ultimately affect your day moving forward. It's that first minute that you start to have, again, that emotional intelligence that we talked about last episode really starts to play in there. That first impression is so big, and it sets up the communication for the rest of the day.
So I'm curious, Ray, if this is something that you deal with a lot of students coming through. You work at a large facility, and you have a lot of these relationships happening on a daily basis. So when you're talking to them and you're giving them this advice, put yourself in preceptor's shoes. Have you noticed a change just with your staff talking about how they've appreciated that? I guess from a CRNA's perspective of having people that can kind of see both sides of the coin, and you have students that are aware to think like this, because that was something that was never communicated to me, and I think that would be really informative and impactful.
Yes, we have. It's a stark difference from those students that choose to engage in those conversations and those that don't. I think there's this sense that, gosh, if I convey that I'm not prepared or that I'm not at that level, they're going to think less of me. And the reality is that's not the case. We try to encourage people to just be ready. These days we have electronic oral control boards, so the students know what they're doing the next day. That gives them time to prepare and be ready. Nothing is worse than when you ask a student, hey, what are they doing in the procedure right now? And the student does not know the answer, right? Nothing conveys a lack of preparedness more than that. So one of the things I used to always do, and I encourage our students to do, is have a handy guide ready, whatever reference guide that you like, whatever you've trained with or enjoyed using, or you can access quickly, have that ready just in case there's an add-on into your room or a case that was canceled. All of a sudden you show up in the morning and it's not the case you prepared for. So at least you can have the basics. You can have an idea of what to expect. What are they doing? How's that going to impact my anesthetic? And it's okay to say, hey, it was an add-on case and you don't know all the details, but at least if you know the gist of it or the majority of it, and you say, hey, listen, this was an add-on case. I reviewed as quickly as I could. This is all I know. That's way better than I don't know. And for those people for those students that do have a run-in with a difficult preceptor, that's something that we ask them to convey to us. Hey, listen, your education, your training is important to us too, because one day you'll be taking care of us. We really want to know, because we want to set you up for success, and we don't want that type of learning environment. And in fact, that's one of the reasons why the National Care Team Advisory Committee that I'm on devised a Preceptor 101 guide. So we share that. We've made that available system-wide. So it has things about how to engage students, how to prompt students for this information, just in case they don't want to prompt, right? How to treat students, how to communicate with them, because communication is huge. Even a simple text may be conveyed incorrectly. We tend to add tone to a text message, or we take it out of context. So trying to be as sensitive as we can and put ourselves in the shoes of the learner so that we can help them get what they need to get, but at the same time, make them feel welcomed. And it really is, it's those little things that make a big difference. But I agree with you, that first minute of conversation with the CRNA is huge. It really sets the tone for the day. And I think it's such an important part of it. And that kind of leads me to the next bit of advice that I share with them is you've got to take ownership in your own education, right? You've got to take that extra initiative, because not every CRNA you work with is going to be engaged. Not everybody's going to be Cole or Tanner asking you about your experiences doing all those things. Some people are a little more quiet, and that's okay, right? And some people don't really engage with students as well as others. Some are not maybe as familiar with the material or more current. Maybe they've been practicing for a while. Maybe there are a lot of students that are really bright, and you might find yourself in trouble. So, taking kind of ownership is the next bit of advice that I share with them. And that could be in the form of being prepared, asking for feedback, checking in with them. I like what you said about saying, hey, this is what I've studied thus far. This is how I think we're supposed to do this case, but how do you do it? Because there's several different ways to do it. The three of us may do the same anesthetic differently, and I think that's where the art and the beauty of anesthesia is, that we all get the same outcome, but we do it just a little bit different. And it's funny, I often tell people it's like cooking. We all got our recipes. We've all learned a different way, different technique. It's which way you're most proficient with. And that's what I try to tell students all the time. Is like, look, you got to learn a lot of different ways to do an anesthetic. Do it the way they'd like you to do it that day. Ask questions. Why are you doing it that way? Can you share with me? And do it in a way that doesn't seem to challenge them, but mostly because you're trying to fact find, trying to understand why this works for you. Because you might gain a little insight that may change your perspective on how you do that particular case. Something may stick, and later on when you get to drive and it's your anesthetic, you may take tidbits from everybody's experiences and come up with your own way. And as you continue to learn and refine your craft.
Yeah, 100%. I think if I look back at my training, my anesthetic today is a conglomeration of at least 50 different forms of anesthetics that I saw people do. And I took different tidbits from each one. And one thing that I noticed along the way is that each preceptor may have had at first what I thought was a very unique or interesting way of doing something. And when I then opened up and asked them about why they did it that way, rather than challenge them on, well, I think there's a better way to do it, I got the response that made me really open my eyes to experience shapes people's practice. And the reason that they were doing certain things was because of something that had happened to them on a previous anesthetic. And that's happened to me, even in the few years now that I've been out. The first patient I had, actually the only patient, thankfully, so far that I've had code in the OR was 2 months after I graduated or 2 months into starting at my first job. And it was just a lap chole, and a patient coded while I was waking them up. They were back breathing spontaneously, and they coded. And we found out later, I had relieved halfway through the case, and the patient ended up having severe aortic stenosis. We thought it was just mild aortic stenosis. And when the stimulation had stopped and they had just finished closing and I was waking the patient up, I mean, my gas was off and it was wearing off, but it was still enough of an anesthetic on board that when the stimulation stopped, their afterload just dropped, and they ended up coding 6 times and ended up passing away from a lap chole. And from that point moving forward, the thing I always check every echo for, first thing I look at is both EF and then if they have aortic stenosis or not. And if they do, even if their pressure is 140, I keep a trace of phenylephrine on all the way until I see the whites of their eyes, just because I was scared to do anesthesia for a month after that, because I didn't want that experience to happen again. And so that experience has shaped my practice. And so I have students that are with me, and I'll tell them, hey, this patient has moderate to severe aortic stenosis. We're not going to make them hypertensive, but until you see the whites of their eyes, I want you to keep at least a phenylephrine drip on, at least until we're rolling out of the room and heading to PACU. And there are things like that from other preceptors that they may have had something that you would have thought might have been off, but ask them about that, figure out why. But along the way too, as Ray said, you're going to see so many different ways of doing things. You're also going to learn 100 ways not have how you want to do your anesthetic, and that's fine too. Every day is a day that you're learning. You're either learning something that you're going to add to your anesthetic or something that you're going to potentially not add to your anesthetic. But the key is not to challenge necessarily the preceptor, but I should rephrase that. You might challenge them, but in a way that seeks and asks them to explain or to basically, explain how and the why they're doing something, rather than challenge them when you think you have a better way to do it. With that in mind though, Ray, so something that we just talked about at this conference actually is several conversations last night was about what we're talking about with taking ownership of your education. And that's something when I look back, how when we're all at this level, we're all doctoral students. We're going back, we're earning pretty much the highest degree that you're going to get. And at this point, we're not necessarily expected to be babysat through our education. Really, our education, you take ownership and you take the privilege to do this, to learn and to grow in this anesthetic community and to become a well-rounded provider. But really, the majority of your clinical experience and your clinical growth is going to come down to your discipline and how much you take ownership of your education. And especially when you start going through all these different clinical sites and you're with these preceptors, your instructor or your technical superior of your program is not standing right over you. Yes, you have a preceptor every day that's different every day, but it's easy to become isolated and lost, where you may have a bad day with the preceptor and a bad day with another preceptor, and that doesn't necessarily get reported back to your main academic supervisor. And you can kind of get lost along the way. But if you don't take ownership and full accountability for your training, for your clinical experience, you're going to regret it in the long run. When all of a sudden you're now taking care of the patient on your own, you don't have a preceptor to back you up when something happens, and you're looking back wishing you would have taken more accountability. And I think as preceptors and as on this side of the things now, that's why looking back, I'm so much more appreciative when I see a student come into the OR and they're right off the bat explaining to me what they've done up to this point, but also where they're weak on and what they need to grow on. That just tells me this is somebody that wants to be a good provider, that wants to learn. And again, that removes the nerves and the stress from it when they come in and have an open-ended conversation with me right away, and we're able to just set the ground exactly where I know what they need. And then they've also explained to me how I can be helpful to them. And I think that just speaks volumes to somebody that comes into the OR to have that type of conversation right away to start the day.
So I guess my question for this, Ray, is what does that look like? What does that look like when you are, it's easy to say we want to take ownership of our education, but what do you see in students who come in that are taking ownership? What does that look like on a day-to-day basis?
I think it's a great question. And I think, I had the opportunity to sit on an interview panel last week for Fairfield University here in Austin. And I picked the brains of the people that were doing the interviews. And one of them said to me, and it resonated, we were, trying to interview so many different applicants, trying to figure out, okay, who's going to be successful, who's got what it takes to get to this program. Adaptability, flexibility, are huge things. Moldability, reception to feedback, and are things that they're looking for. They need people that are receptive to feedback because it is a long training program. You're going to get feedback along the way. I think something that really shows accountability or ownership as a student is to seek out feedback. That's something that I do even to this day. I seek out feedback not just from the people that I'm working with and the people that I like, but honestly, I seek out feedback from the people that I think maybe are not as I'm not the most popular, or maybe the most difficult CRNA to work with, or maybe the ones that are most quiet. They're the ones that are going to give you some honest feedback. And sometimes you got to take feedback with a grain of salt, because sometimes there's a level of expectation. Everybody's at a different level. But I think what you're looking for are common themes. Am I continually hearing that I'm not prepared? Am I continually hearing you need to work on these things? I think seeking out feedback is probably the biggest thing that I see that sends me a message. Hey, this is somebody who wants to get better. And prefacing that feedback, hey, listen, I'm just really trying to do the best that I can here. I've been working on X, Y, or Z. How do you think I'm doing? And please be honest with me. I really want to get better. And I think that's really sends a positive message. And it kind of sets the course for the day on what they're going to focus on. It's humbling because you're exposing yourself. You're making yourself very vulnerable.
I love this because this was something that we were told in school that this was something to do, to seek out that feedback. And I last week had somebody and they came in at the last second. They were in another room all day and that room shut down. And so they were coming over to join me for the rest of the day. So the student walked in, the patient is literally already wheeled into the room and we're getting ready to intubate. They come in, I tell them like 10 seconds of history. This is what we're going to do. Go ahead and intubate the patient. And so she did, and she did fine. The patient went to sleep just nicely. And then we got done. We're in the middle of the case, and I said, "So how do you think that went? Can you tell me? What did you like about that? What would you maybe have changed?" I said, "I know that was a stressful situation. You literally walked in 10 seconds before. Just talk to me about it. And it was really awesome because I affirmed with her. I said, you did a great job. Patient went to sleep safely. That's all. So what we're talking about is a little bit of the gravy of like, maybe you could do this more efficiently, or you could do, this is going to help you just be a little bit better. And I think if you're not seeking out this feedback, maybe you do get through your day and it's safe. But there's a million little things that the preceptor's seeing and noticing that they can just give you a little bit of feedback. And it doesn't need to, be taken personally. These are just things that, of course, you're watching. I tell students all the time, if you came in and precepted me for a day, even as a student, I'm sure there's 100 things you would tell me to maybe do differently, or maybe you should have checked this, or because you're the one that's sitting at the room just observing, you pick up on things. And so it's not necessarily because I'm better than you, or I have, this position to just talk to you and tell you all the things you're doing wrong. If you were in the room with me, you would have things to say to me as well. So don't take it like I'm saying this personally, but I think you miss out on so many of those nice, helpful things when you're not seeking that feedback. And I thought you were going to say, with that question, I thought you were going to talk about seeking out cases and doing these other things, but I think you went way below that, like rock bottom, seeking feedback and looking for those opportunities. That'll feed into seeking out those cases, seeking into finding areas where you can get better. Because if you hit the nail on the head, if you're looking to get better, then you're naturally going to be doing those other things that you're talking that typically come up with finding different cases or finding different procedures to be in. So that feedback portion is, I think, just critical. And we're talking about, the whole point of this podcast is talking about building trust. And I don't think there's anything with me as a preceptor that'll do that faster than being receptive to feedback and asking for it.
Another little thing that I like to encourage them to do is keep track of your progress, right? Keep track of your wins, but also keep track of your losses, and share that with them. Hey, listen, I am really working on my ultrasound skills. I've got a personal goal to do 100 ultrasounds by in 3 months, right? I want to do 100 ultrasound IVs. This is a thing I did for myself, and I shared that with my colleagues. Hey, listen, I'm ultrasound's new. I really want to get proficient at it. My goal is to do 100, and I kept the log on my phone of all the times, all the things that I were successful, and the times that I weren't successful. I made a note as to what I learned. So every failure wasn't a failure. I didn't see it that way. I saw it as an opportunity to learn. It's like, okay, that's a successful way not to do it, right? And so I kept journals of cases that I struggled with, cases that I did well. I would also do things like I would say, hey, I don't use the Miller blade that much. What do you like? Especially with people that love CRNAs that love the Miller. Miller people love to talk about their Miller blade, right? So I would say, hey, I don't use the Miller. All of a sudden, we're using the Miller the whole day, right? Or, hey, I've never used a fast track LMA. We're using it for every single case. Or I've never done, X, Y, or Z. And people like that. Sometimes that you just need a little bit of a push to try something new. It helps also when you're in the right type of training environment where they're receptive to that type. And there's always a time and a place for this. It might not be the right surgeon, it might not be the right case, whatnot. But when those opportunities present themselves, and if you kind of express it or convey a genuine interest in wanting to learn those things, people make it happen for you. They really do. And it really says something about yourself by making yourself vulnerable and putting yourself purposely in those uncomfortable positions. We do a thing as a tail end of their training. They can kind of pick the cases that they're doing at the end of the day or whatnot. And believe it or not, they may not think we're watching, but we're looking to see what they pick. You shouldn't pick the hardest stuff all the time, but if you're constantly picking the lap choles, the lap appies, the easy stuff, what is that saying? And honestly, what are you learning from doing that in your training when you should be getting ready to do? Why not do the hardest stuff that you can, but while you're still taking care of yourself, but do the hardest things that you can now while you're in training so you can get that experience so that when you are on your own, you have that competence. You might have done one or two of those in training with somebody else while Cole or Tanner were there to make sure that you didn't hurt them. So I think it really says a lot about a person. It conveys work ethic, and it conveys a type of, I think, CRNA that we're all wanting to be part of our practice. Because at the end of the day, they may want to practice there.
Yeah, these are all just, I think, points that I would have loved to have really been addressed and actually been taught before I even really approached my clinical rotations. One thing I want to add that just came to my mind is I feel like anesthesia students are so competitive. Maybe that's just in our program. Tanner and I are super competitive, so we like to compete against each other. But I feel like just from talking to a lot of people, is you get in, especially the first few months of clinical, you start to have, there's always chatter between each other, right? And you start to have these noises in your head where you're like, well, this person had 3 different opportunities to do this, and this person already has done 4 central lines already. I haven't even attempted 1 central line yet. Or this person got to do these big cases, and I'm still getting in these smaller cases. Like, and you start to have this competitive thing that goes into almost causing doubt of, well, why aren't I getting those things? Why am I not successful at those things? Why are they getting opportunities that I'm not? And in the grand scheme of things, everybody's going to cross the finish line. As I mentioned earlier, we're in a doctoral level program now. It's no longer, are you the best in your class to go on to the next level? There's no competing against each other to be the best to advance yourself further. This is we need to, as a team, all get across the finish line. We're all at the end goal. Like, there's no other higher education really after the doctorate degree in anesthesia. And so especially in those first few months, my advice would be take what you hear from your colleagues with a grain of salt, because you're going to hear all the amazing things that they've got to do, but I guarantee you they're not telling you their mistakes and the things that they've messed up on. And don't beat yourself up mentally when you're hearing certain things, and that those moments of doubt start to creep in of, well, am I not doing a good enough job? Am I not keeping up the pace that I should be? Because at the end of your clinical, when graduation date has come, you're all going to have your numbers. You're all going to have different levels of experiences, just simply because different things are unpredictable when they happen in the OR. But you're all going to have the needed and the necessary experiences to graduate. But then the next level of that then becomes, obviously, if you keep putting yourself in positions throughout your clinical training to potentially have those unique things that come up, you're going to see more of those. But from a fundamental level, don't necessarily get hung up on the idea, especially at the beginning, if you seem like you're falling behind. Because again, if you think you are, that's again where you talk to your preceptors. Tell them, these are the things that I actually want. Can you maybe in the next few days try to put me in these kind of rooms? This is really where I want to go. And again, that all comes down to communication. If you're not communicating with those that are in charge of giving you opportunities, they may not know to put you in those situations to grow. And so it's coming to the realization that your preceptors are there for you. They have your back. They're trying to make sure that you're going to be a successful anesthetist. So again, I just think that's another thing that's kind of been weighing on my heart lately, especially talking with several just different people from different clinical sites, different schools. I kind of get the same theme that we're just so competitive with each other. But at this point, you're all in it together. You're all striving across that finish line as a team.
Yeah, I think we're all A-type, and I think it's a great message to deliver. I remember, hey, how many A-lines have you done? How many central lines have you done? Hey, I did this block today. And it's normal to kind of have a little look over the other side of the fence and that grass looks greener. But I agree with you. At this point in time, we're just all trying to be successful. We're all trying to finish. Nobody's spouting numbers or stats when you're getting your degree or you're graduating. When somebody comes to interview with me, I interview a lot of people. I never ask them, hey, how many central lines have you done? Or how many intubations have you done? Or any of those things. They seem so important at the time. But at the end of the day, it's the skill that it's a lot of factors you contribute to where you're training, your clinical side, time of day. Are you doing nights? Are you doing call? All those things. You may just get lucky that you were on call when the heart transplant came. We can't predict those things. So I think that's a great message to kind of alleviate any pressure or stress of, gosh, I'm behind or haven't got there yet. I'm a big believer in quality versus quantity. It's kind of like working out. What's the difference if you did 15 sets with no weight versus 3 good quality sets with the appropriate weight? I mean, where are you going to get the benefit from? I think there's benefit in both sides. So I think it's a great message.
Awesome. Well, Ray, thanks for coming on. I think this is, like Cole said, this is all stuff that we felt like would have been so helpful for us, especially while we were in school to, whether you're just starting out or whether you are in a spot where you're rotating in lots of different places. Of course, you need to have the physical things covered. You need to have an airway plan. You need to know how you're going to keep the patient asleep. You need to know the steps of the procedure, like you were talking about earlier. But this goes beyond that of how do you find success through all the different relationships that you're going to encounter throughout your clinical journey. How do you build that trust, and how do you find a way to thrive as you go throughout these different settings? So we really appreciate having you on and just sharing your expertise with us. So thanks, Ray.
It was an absolute honor to meet you guys, hang out with you guys. You guys are really special. You guys inspire me to do more, and I love being around people like yourself. So thank you for this opportunity. It's such a pleasure to meet you, and I look forward to continuing our relationship, visiting you guys, having you guys visit me here in Austin. Let me show you some Texas barbecue, and maybe join me at a UT football game.
I love it. Go Irish.
Thanks, Ray. Really appreciate it.
All right, guys, take care.